Hi, Karen. This is week 3. My observation was a support group for patients that we're going to have colon surgery and potentially going to have either temporary or permanent ostomy put in as a replacement for part of the colon. All right, we'll just begin. Environmental demands that I saw, it was a typical meeting room. It was in a professional building outside of office hours, so it wasn't necessarily busy. The room had 8 chairs, kind of in a horseshoe shape, had an overhead projector, had a table in the middle where people could view it as they were meeting, that had supplies on it that you use when you have an ostomy. Kind of nondescript. One thing I noticed that was a demand, but I didn't know where to put it, so I put it in environmental. I noticed that once the little video started playing that it didn't have any kind of closed captioning. It was made in the office by the doctor and his staff, and it was, well made, decent video, but in my world, it did not have closed captioning as it would have needed to have, or as an interpreter, I would have had to interpret pretty complex information, although it wasn't presented, quickly, and they tried to do it in layman's terms. It still is complicated. There were 3 patients in the room that were pre-surgery, and they were there as pre-support. There's also post-support groups for people that end up with either an ileostomy, which is a temporary opening from the colon outside with a bag, or a permanent ostomy, which means that the colon has been redirected and cut. Usually it's lower bowel, rectum cancers or obstructions or trauma, something like that. And it comes out of the skin, and you have the same kind of equipment. It's on an ileostomy is on one side of the body because it's temporary, and the colon's redirected, and at some point they'll go back in, do a second surgery, and reconnect the colon, and there's enough room to let the ostomy heal and close up. And with the permanent ostomy, enough is cut out that you can no longer redirect it, and it has to, a short piece of the colon comes out through the body, and it's actually a live intestine that you see on the person's abdomen area. Probably got a little ahead of myself there. So the patients, there were 3 of them. There was a patient representative, I wanted to use the word advocate, that was there that had a permanent ostomy, and they rotate out patients of this particular surgeon to come and talk to groups, kind of be the cheerleader, rah-rah. It's, it's okay, look at me, I'm living with it. This guy was kind of quiet. He was in his 70s and 60s. He was in his 60s. It was another patient was in the 70s, and just kind of quiet during the time. He did try to make some jokes, and he was nice enough, but this is not moving. I had a physician's assistant that was there, very nice. Office assistant that was helping just kind of document who was there. Follow-up that the doctor needed to have with them, and then family members were allowed to come. Each of them had a family member that was there with them, which was nice to see. They looked like deer in the headlights most of the time, but that's okay. They were introduced to the information. List of terminology that was related to colons, disease, gastrointestinal kind of issues that people may have, obstructions. We talked about cancers, talked about when the colon is spastic, talked about the temporary ileostomy versus the permanent colostomy. A stoma is the actual piece of I keep going back to the word live intestine that's coming out of the body, that you put the bag on so that stool is able to come out there. It's redirected from the rectum. A lot of issues, a lot of discussion about that. Things that they find when they go in and do a colonoscopy are polyps. They can be precancerous, cancerous, completely benign. Dietary issues, genetics are a factor. They talked about diverticulitis, and what that means. That's also seen, typically with an endoscopy, but it can also go down, and the diverticulitis affects the stomach, and it puts little pockets in there where you have dietary concerns. You can't eat seeds or nuts, skin things. A lot of colon health foods and dietary things apply to diverticulitis, hiatal hernias, and once you have an ostomy. Bowel stool, ostomy care, the supplies that go with it. The ostomy side, as I was saying, is what's outside on the abdomen. So a lot of discussion about terms that are very new to people. We don't talk about this or know much about this. We just have our normal bowel function and don't think about life-altering diseases or reasons, syndromes, whatever, that could change that. Crohn's is a big reason that a lot of people over a period of time, their colon doesn't function anymore, their large intestine doesn't function anymore, and end up with a colostomy. Interpersonal demands, there are 3 patients. The physician was in and out. I did not have access to anything before they came in. I was familiar with reasons people get it because my father has one, but I did not know their specific issues or medical history. A little bit came out in the meeting. Someone had cancer. Someone had Crohn's disease from a very probably early 20s, and there was also some issues about alcohol use and inflammatory disease, the bowel obstruction that ended up being part of this patient's history and now reason for having surgery was kind of unknown, just in general discussed. Someone else had precancerous polyps, inflammation, and some bad diverticulitis, and they were going to have to go in and see what could be done. There's a possibility that out of these 3 patients, maybe one won't end up with a colostomy with the surgery. It'll just be a surgery, some kind of internal procedure, and they heal and are on their way. Chief complaint was the upcoming surgery and the disease syndromes problems that each of the individuals were having. So there wasn't one chief complaint. The reason for the visit was this support group, and it really does provide a lot of information. The follow-up is good with the doctor, with family members after this, finding out more information and kind of just figuring out what the heck is going on and what they're in for, because it's unknown until you go in for surgery. You don't plan to come out with an ostomy, whether temporary or permanent, but it happens. So preparation is a good thing. Preparing for the worst and hoping for the best, I guess. Medications, different treatments have been tried with the patients that were ineffective, so surgery was the next line of defense. This was a surgeon, so he was not the primary care doctor for anyone that was in the room. And basically it was pretty simple. I arrived about 30 minutes before. Once everybody kind of started getting there, I had introduced myself to the staff. I had met them, but I'm in a sea of hundreds of people they see a week. So I reintroduced myself to them, asked if they needed any help getting set up. It was very informal. As patients and people arrived, I did include myself in the group very temporarily and just kind of explain briefly why I was there, that I was doing it as a project. However, I had a family member that did have an ostomy, and so I was sensitive to the issues. I wouldn't be using names. They weren't very interested in me. There was a pretty high level of stress related to this, even though it was informal with their families, the doctor in jeans, the PA, in casual clothes. It's still kind of daunting to think that this could happen to you. I didn't sit too far away, so I wasn't like in a surgical room where I was back in the back or trying to hide in the back of an office while somebody was getting an exam. I kind of was close enough where I wasn't a participant in the group, but I was not obviously segregated from them either. Started with a short video that just had general information. The physician had put it together. It was a well-made video. It was only about 12 minutes, but it gave them an introduction and a place to begin questions if they hadn't formulated any on their own. Let me go back a little bit. Paralinguistic demands. Their hearing participants were very quiet at first, very hesitant to ask questions. I wondered, with the quietness in the room, if a deaf participant, I wondered if it was the terminology, the concept, which is so foreign. So I really felt that a deaf person in the room would have magnified that, and probably, unless they had done a lot of prep work themselves or were familiar with medical procedures and the terminology surrounding the colon, that they wouldn't have asked many questions potentially. One of the female patient was very soft spoken, repeated herself a lot. Hispanic male, fluent in English, strong accent but fluent. Wife from Mexico, mentioned that once or twice. Was not as fluent in English, probably a housewife. This is my thought world. Raised the kids, didn't go out into the working world, and didn't prefer to use English. The patient that was there, the patient representative, told his story and what had happened, the cancer that he had had, a fairly young age, out of the blue, wasn't sure, wasn't family history of colon cancer or anything, and he gave a lot of description about what a day looks like. What do you do? What do you do when you get up in the morning? How often do you have to change your bag? He volunteered a lot of information because there still at this point weren't a lot of questions. How do you pack to go out of town? He was still working. What do you do if you happen to have the flu? The flu causes diarrhea. And I see a typo in here. I'll correct. Or I may not have time to correct it since I'm videoing. The patient representative also talked about, it's kind of like the stages of death and dying that you go through when you have any kind of disease, and you kind of go through the 7 stages. And he talked about being in denial, and I'm this big strong guy and this is not going to affect me. I'm going to get through the surgery and I'll be fine. And he woke up with a permanent ostomy. And so then he turned it back, although he was quiet spoken, into kind of humor, talking about blowouts, ostomy noises. Yes, you can fart with an ostomy. It just comes out in a different location. So that got a little laugh, but people were just not really thinking it was very funny. And it's not. It's a serious situation. But he did, not making light of it, tried to make everybody comfortable. One of the other gentlemen that was a patient that has not had surgery yet spoke about, I'll never have to get a colostomy again. And around the professionals in the room, there was a little kind of, murmur. And it was like, oh, yeah, you do. And in fact, you just wear these really long bags that go down past your knees. And that's your modification for not being able to go and use the restroom when you're doing prep for a colonoscopy. You probably never had one, lucky you, but in future years, you will be there. The meeting ended kind of quietly. I did not hear the conversations that happened between the providers, the doctor, and individual patients, or with the families. They were available. They stayed around for a long time. It was just quiet. I can't express how it wasn't a lively discussion of symptoms and pains, and it was more personal than that, is, I guess, the best way to describe it. They were somber, not really joking around a lot. The real life experiences, I think, helped. The doctor is very good about layman's terms, very good about laying it out in a way that's understandable, but it's still a lot. Conflicts and communication were resolved pretty quickly, and it was just more question and answer. Not being able to, they weren't there to do specific things. They were there to discuss generalities and about procedure and what it would look like afterwards. To my top 5 demands, as you can see, I've run out of time, so I'll let you read them here. Terminology was big. It's a steep learning curve too. It isn't within our realm of things that we know very well. I went way over. Sorry, Karen. Controls I had, I'm not squeamish. I can keep a poker face. I have experience. I have knowledge of the care and equipment. I knew what to expect in the discussion. Prep, I'd attended this kind of meeting before with my father. I knew about colon diseases and surgeries. I had spoken with him. And I have a relationship with the physician, so that was nice. All right, I'm going to end there. Let me know what questions you have. Thanks.